can do yours first. We can do mine first. We can whiz through both of them. Which would you?
Let's do yours first.
Okay.
They're up.
They're up. Okay. So this first one is look what the cat dragged in, and this is a 34-year-old lady who came into the emergency room with hip pain, and she said she just, lost her balance and just tipped into her kitchen counter. And she said, gosh, I have some pain, and it's in my groin, and it radiates up into my abdomen. And so they took a hip film, and she'd fractured her femoral neck. And incidentally, how many times have you heard that? Incidentally, they found a 3-centimeter right adrenal mass. Now, this mass was benign. Look at the Hounsfield units, less than 10. This is the most benign, 60% washout in 10 minutes after contrast. This is the most benign thing you've seen on the block in years. And her BMI, though, she keeps telling me, is 28. She's increasing in weight. Her blood pressure, though, the day after we had her in the hospital, she'd calmed down. Blood pressure was really okay. When she came to the ER, it was high, but, so would yours be. Okay. So let's take a quick look at incidentalomas. We said, well, ma'am, don't worry about it because most of these, about 83% of them, are just warts. There's really, nothing there. And if they do secrete something, it's probably cortisol, or they could be a pheo. But, with those Hounsfield units, they're not a pheo. So we looked at some laboratory. After all, she was in the hospital. She had prediabetes. She had a low HDL. She had high triglycerides. Calcium was normal, liver was normal, potassium was normal, kidneys were normal. And so the orthopedist said, I'm not operating on that lady until you tell me she doesn't have a pheo. I said, she doesn't have a pheo. Hounsfield units are too low. And he said, I'm not operating on that lady until you prove to me biochemically she doesn't have a pheo. So that was a very good thought. Or he said, or hyperaldosteronism. I said, she has about 0.5% chance of having hyperaldosteronism. And she has no hypertension, she has no hypokalemia, so...
I'm surprised the orthopedic surgeon knows what aldosterone, or how to pronounce it.
We have a very bright... Okay, so do we need to screen for a pheo? The newest data says no. If your patient doesn't have hypertension, Dr. DiPetti may disagree with that, but if it doesn't have hypertension and the Hounsfield units are really low, we do not have to screen for a pheo. Anyway, he wasn't happy. So I said, in case I fracture something, I always want to make the orthopedist happy, so I got a plasma fractionated metanephrine. Those are really sensitive. So it's going to be positive she has a pheo. They're also pretty non-specific, but I didn't tell him that. We went right on. It was negative. That's good. And so the most common hormone overproduced, though, is, I'm getting to osteoporosis, really, is cortisol. 11.3% of the little adenomas you see produce cortisol. So we got a urine cortisol, and it was 2 times normal. Not high enough for Cushing's, sorry. So we did an overnight dexamethasone suppression test. The orthopedist is getting a little antsy. But the result was, 2. And you say, it's 5. No, they changed the number. It's now 1.8. Normal is 1.8 or less. Her ACTH was low, so she had an adenoma that was producing steroids. Aha. So why did she have the fragility fracture? She had a DEXA scan 2 years before, and her Z-score, remember, she's under 50, so we're going to use the number of standard deviations below her age-matched mean, was minus 2.3. Minus 2 plus a precipitating factor is osteoporosis. Aha. This lady had osteoporosis 2 years ago, and she had subclinical Cushing's, and she had a hip fracture. So, subclinical Cushing's, the 24-hour urine is less than 3 to 4% of the normal times the normal range. The 1 milligram dex doesn't cause suppression, but they can have a lot of things like an abnormal A1C, as she did. She had prediabetes. They can have osteopenia. They can have increased cardiovascular risk. The question is when to treat these people with a little extra steroid. We waited too late for this lady, right? She had a hip fracture. So you look around your practice when you're checking the obese people who have a little bit of diabetes and a little bit of problem with weight loss and so on. When you're checking for Cushing's, if they have subclinical, you want to watch them because it gets their bones particularly. So you want to take a look at the progression of their DEXA and look at the Z-scores in most of these people because they're going to be under the age of 50. And be sure you take a look at that annually. Okay. So the indications for surgery, well, younger than 40, subclinical Cushing's, they took out the adrenal mass at the same time they fixed the hip. And it worked very nicely. You can do a laparoscopic adrenalectomy. It's really nothing these days. I mean, they flip you over, they go in, 28 minutes later, you're out of the operating room. So, okay, it's hard to argue with that, right?
Correct.
Make sure she has 1,200 milligrams of calcium. If you're not going to operate on these people, make sure their calcium D are okay. You can watch subclinical Cushing's. Sometimes it goes away. But what are we going to do for this lady? Besides the calcium and the D, are we going to put her on a bisphosphonate? No. We're going to give her calcium and vitamin D. And we don't know if her bone density is going to increase because she's getting pretty old. If you're a teenager, and I give you steroids, and I stop them, you get bone back. If you're in your 20s, you get your bone back. As you get into your 30s and 40s, I don't know if you're going to get your bone back. So you're going to watch this lady carefully with DEXA scans and make sure she gets her bone back. And if she doesn't do it on calcium and vitamin D, you're going to try to use a bone stimulator. You're going to try to use teriparatide or Forteo. It stimulates bone building in these people. Because on chronic, low-grade excess steroids, which is what she had, you don't get rapid bone turnover. You get, it just ooches away. So, okay, that's it.
Well, I don't know if your orthopedic surgeons are different than our orthopedic surgeons. It sounds like you have very bright orthopedic surgeons that wanted to work up, and they called you for...
You're afraid to operate.
Well, I mean, I'll tell you my case. My case is me. I fell last winter, and not a significant fracture, but enough that they recommended hip surgery. And the orthopedic surgeon, same thing, just wanted to work up to make sure he wasn't operating on something weird. And it turned out I had 2 lung masses, and they were scared because I had a history of cancer, those of you who've known me for over the years. And I had the lung resection and everything was fine, but the orthopedic surgeon wouldn't touch me until I had a workup. Now, for the OB-GYNs in the audience, if one of your patients says, I'm going to the, especially, she was 34, right? Mm. Yeah, and I'm 34, so.
I won't say anything.
Yeah, if they say I'm in the hospital, why don't you stop by, or especially those of you in, medium-sized, reasonable-sized towns, and so you know most of your patients, and they say they have hip fracture and have surgery. If your orthopedic surgeon is not recommending a workup, it's probably a good idea to while you're there, recommend a workup. I don't know if I'd get an extension of a workup, but I would probably call somebody like Dr. Piziak, call an endocrinologist in, take a look at that patient before they undergo major surgery. But I'm hoping that the orthopedic surgeons are of great quality everywhere, but
if it looks funny to you, get a workup. Really, I mean, if somebody comes in and they fractured their hip when they're 26 years old, and I see a number of those people, and they have stress fractures, but they're usually heavy runners. They run like 50 miles a week. They go in triathlons, and they're all kinds of athletes. And maybe you are runners. It's fine to be a runner, but you don't want to run your bones into the ground. Most of them don't take any calcium. When I talk to them, they don't like dairy products. They eat a little a yogurt now and then. So if the young person fractures, think problems other than osteoporosis or osteopenia. Even osteopenia on the DEXA, you got to think there's maybe a problem with that young person.
What do you consider young?
Young. See, it gets older every year. I'd say around under 50. If you have to use a Z-score, you should then you really should begin to think about a workup.
Yeah, I mean, I do osteoporosis. Most of the patients that come to see me, are older than 50, and you're getting them their, pre-Medicare workup and turning out their working them up before you send them off to their internal medicine doctor. So, I see pretty average osteoporosis candidates. The ones who have any complication, the slightest thought of a parathyroid problem or really bad diabetes, I'll refer to an endocrinologist to take a look at. Vice versa, the referrals that you guys will get and that we'll get are the young women, the young women that have stress fractures, the college athletes that have some problems, and and the endocrinologist, well, Dr. Piziak's very bright, but some other endocrinologists think about, gee, what if she's on Depo-Provera for a few years? What if she's wants to be on birth control pills, and the horrible cases where they try to put them on bisphosphonates when they're 19 years old, and then all of a sudden they wind up pregnant. So we'll get the referrals coming backwards too. But I would agree, under 50, definitely think of a workup.
And the workup is very short. I send them right over if they have amenorrhea. So you can get hypogonadotropic hypogonadism, and that's what you see in most of these athletes. Not only statistically do they have a low calcium intake, they have menstrual irregularity. And so then you don't have estrogen. So you're really behind the 8 ball. You don't have any calcium to build your bones. You don't have any estrogen to preserve them. And so you need to speed right over there. How about your people on low-dose, long-term OCs? I see some of them with atraumatic fractures, stress fractures. You know, especially if they're athletes.
Yeah, well,
it doesn't seem to protect them as well. Is that true or false?
It's true. The estrogen is so low. It's too low. It's not preventing ovulation, and the birth control and the low-dose pills are working because of the progesterone effect on the cervix and the endometrium. So you're not getting the benefits of estrogen, and you're getting birth control benefits, which is great, but you'll wind up, if they're on 4, 5, 6 years, you'll wind up with some low bone mass.
Okay, question. This is such a quiet audience. Now, when I sang in the nightclub, we look out at an audience like this, and it's almost it's 8 o'clock in the morning, and we say, boy, you know, we got to stir something up here. Okay.
They'll join in.
They'll join in? Okay. Good report or bad report? It's a 62-year-old Asian woman. Remember, Asian people less likely to have fractures. Is that because they're less likely to fall down? Yes, because their family, that's in Asia, the teenager, when I was in Japan at the meeting, their hip fracture rate was so low. And I said, how come your hip fracture rate is so low? And they said, because in our extended family, the teenager is assigned to keep grandma from falling down.
Don't walk so fast.
And so, you know, this is a loss of faith should grandma fall down and break anything. And also, now we know that Asians have a different microarchitecture, and so they're more resistant to fractures, even at lower bone mineral densities. So, she's been a drug holiday for a year. She's had no fractures ever. And based on FRAX, the 10-year probability of a major osteoporotic fracture is 9.1%, and her hip fracture, when we're going to look at 1.8%. Would you restart bisphosphonates in this lady? The major problem here is that she's had a FRAX calculation. If you're in England, you probably wouldn't. If you're in the United States, you'd ask what her bone mineral density change was, because we don't believe that FRAX is going to help you after you've been on a bisphosphonate, and they do. Any thoughts about that?
Mm-hmm. Yeah. Go ahead.
No, I was asking for your thoughts.
Oh, my thoughts?
There you go. There's the answer.
I always give them bisphosphonate.
If they've been off for a year?
Yeah.
Whether or not they've lost bone.
She's lost bone?
Well, I don't know.
I know.
She got her FRAX calculation there. Yeah. No, if they've lost bone, if they've lost a significant amount of bone, I think we would agree that you need to start again. The chances of those people on zoledronic acid for 3 years that I told you could stop, you know what the chances of their having lost bone over the next 3 years was? Less than 10%. Like 90% of them preserved their bone for the next 3 years. So even if the insurance company argues, you could get a DEXA scan at 2 years. But if they have a significant loss, then they don't have bone suppression. They just have low bone turnover. Okay. So what are the reasons you would? A significant change in DEXA, a significant increase in a bone turnover marker, or a fracture. They have a fracture that's not an atraumatic fracture, then you need to restart. Okay, this one's my last one. 72-year-old woman, follow-up for osteoporosis. She's complaining of back pain about 4 months ago. And then she said, she literally said this, the back pain is gone after a strange masked man fixed her back. And she was right. The DEXA report showed an increased L1, L4 0.126. That's an amazing increase. An increase of 0.043 at the left femoral neck. Now, that's a piddly increase and is within the error of our scanner, which is mediocre. Now, do you tell the patient that her spine is awesome, her increase is fantastic, or do you look at the picture? You look at the picture. And there's her, sorry, I had to mock that up so you could see it, her vertebroplasty. But vertebroplasties are literally a blue blotch on the vertebra. So you can pick that out right away. So this lady had a vertebroplasty, but the radiologist just read it as a vast increase in, are there any radiologists in the audience out there? Thank goodness. Read it as a vast increase in spinal bone mineral density. So if they're moving through quickly and they're reading hundreds of these, they don't take a long time. Okay, that's my case.
You know, you don't want to insult radiologists or orthopedic surgeons, but you got to ask if their spouse is a orthopedic surgeon.
Oh my goodness, is your no.
I can still go back and say, do you know what they said about you?
Well, you know, and actually you can tell that from the report if they give you the whole spine. Sometimes they just give you the average of L1, L4, and that's what they gave the radiologist, is looking through, didn't really look at the picture and just read and just dictated the report from the just the overview summary. But if you looked at the actual L1 through L4, you could see right away that there was a little problem here. We have T-scores of 3.8. So the L1, L4 one, you've got some spillover from the L3 vertebroplasty. Okay, so let's get yours up so that we can.
You want to? How do I get out of yours? Leave
it to the expert.
Randy, do it. So no, but for OB-GYNs, if you're going to treat patients based on their FRAX and their DEXAs scans, you probably should look at them, and you probably should make sure you have a picture, because with her, had this been the first scan that she had,
that's it,
and you didn't notice the big difference in the case, then you would have assumed she was normal and not even consider treating her.
Right.
So I think it's important to look at your scans. Like if you have time, you just take the course that the National Osteoporosis Foundation puts on, and it teaches you how to do that in one day.
We taught you how to do that in like 5 minutes.
Okay, she'll do it for you in 5 minutes.
No, actually, they do a much better job. But you could get, you can get 90% of those errors with just what we discussed, just by taking a quick look at the picture, because any boob can see a vertebroplasty, right?
Oh well, yeah.
This boob could.
Yeah.
Okay, so
your urologist can't. So I'll insult the urologist.
Oh, come now.
So yeah, it's about 10, 12 years ago, I encouraged all the doctors that worked for me. I encouraged all of them to go to the course, get certified, and do that, and then. Once they got back, they decided they were all going to buy a DEXA machine for their office, and they did well for about 2-3 years, and then, as you know, they reduced the reimbursement from like $220 down to $50, $60 now.
Now it's $42 for us.
Yeah, and they all had these machines that they said, "Will you talk us into buying?" I said, "No, I talked you into going to the course. I didn't talk you into buying a machine, but I was able to get another company to buy the machines back for them, so they're not that mad at me." Just a couple of quick cases because I want to stay on time. So this woman is a 53-year-old. She worked with us back in Oklahoma. Okay. Short, 5 feet, and 112 pounds. Just entering menopause. Former smoker, stopped years ago. Just drank just socially. She exercises. She was a former gymnast, and she took soy medication for the past year in an attempt to treat her significant persistent hot flashes. She got into menopause and had horrible hot flashes, and since she worked with us in our office, she knew how terrible estrogens were. So she went ahead and tried soy. It didn't work. She wasn't really well, and she had some significant bone loss. Okay, so now she's sitting there and says, "Well, I don't like estrogens, or estrogens okay." So there's a bunch of estrogens. What would anybody do? Can anybody brave enough to say what they do? There's no right answer. There's no right. So I really couldn't talk her into estrogens. And
you couldn't?
I couldn't talk her into estrogens.
I can't believe
I know, and I always talk everybody into estrogens. And she still had a uterus, so she would have to have
that's awful.
Progesterone.
Nobody wants that, right? Yes.
Yeah, okay. Progesterone's the problem with the study.
So what do you do about that? Don't stop there.
What?
what do you do about progesterone? She's got a uterus, and I just say, oh, go to the GYN clinic.
I was going to tell you, I'll take estrogen alone. I mean, when I go to our meetings, I'm immediately past president of the International Infectious Disease Society for OB/GYN. So when we have big conferences, not big, large number, but important conferences, they have the president of each of the societies, Reproductive Society, Surgical Society, Maternal Fetal Medicine Society, and I represent the infectious disease people, and we sit and talk about big problems and big issues. And half the presidents are women, and I asked them, I said, WHI, that you were part of the data, and what do you think? And they said we're all on estrogen alone, and they said because we don't want we think the risk, and I agree with them, the risk is in the progesterone, especially the synthetic progesterones, and we just go ahead and monitor ourselves by ultrasound and take a small endometrial sampling every year, but we'd rather just be on estrogen. So knowing that data, I offered her estrogen alone. She still didn't want to do that. The estrogen agonists, the SERMs, I think SERMs are a good choice. And then there's a new drug, and the reason I add to this case is there's a new drug out since last year, and that's the conjugated estrogen and basodoxifene. That in fact she was part of the study 3 or 4 years ago, more than 4 years ago. So that's a SERM, the basodoxifene, with estrogen, and it's an interesting combination. It's got approval for hot flashes and for the prevention of osteoporosis. Mm-hmm. So she's in the non-osteoporotic but osteopenic category. She understood the drug because she was on the study, and basically it's the company's not doing well with the drug because they can't explain, is it giving them estrogen for the benefits of estrogen, the basodoxifene prevents the side effects, or are you giving them the SERM like you would raloxifene, Avista, and ospemifene for the benefits, and the estrogen is to prevent the side effects. And it really is the former. So she'll get great hot flash relief with the conjugated estrogen. It's basically 0.45 milligrams of conjugated estradiol. And then the basodoxifene will prevent her from getting the hyperplasia in the uterus. But along the way, since it's a SERM, she gets benefit for osteoporosis. So that was the best drug for her. What you can't be is the risks of the SERMs are your thrombophlebitic risk, which is if you have a DVT in the past or a high risk for DVT, I'd maybe steer her away from that. But again, she's got a family history of breast cancer. So for me, it was even better. It's not indicated for breast cancer. The FDA wants 7 years of studies. So it'll have to be out another six years before they'll have those studies available to look to see if you have the same cancer prevention as raloxifene, as Avista. If you remember, raloxifene came out first as an osteoporosis drug, and then when the data was accumulated over 7 years, it then got the breast cancer prevention risk, just like tamoxifen. Lots of hot flashes. She can't go with that. She didn't have a choice. She wasn't functioning well, and she didn't have a history of blood clots. So for her, the trade name is Duavi was a good combination for her. So.
Absolutely. Even endocrinologists are using.
You even agree with that?
Yes, I agree with that.
Good.
That's really terrible.
You didn't want you to tear me apart because I missed an adenoma someplace.
No.
It's 5 years later, so let's say it's 5 years from now. Now this is hypothetical, and her hot flashes are gone. Now she has worsening vaginal dryness and dyspareunia. Her scores are a little bit better.
Oh no.
Not much.
Oh no.
What?
You didn't look at the bone mineral density. Oh no.
Oh
no. You can't look at the T-score. Remember, it's a surrogate marker, so you really, he knows because he reads them and gets paid $24.52 by Medicare. You need to look at the.
Good.
You need to look at the changes in the bone mineral density.
Right.
Right. Thank you.
But it improves a little bit. This is the hypothetical part. And again, no history of blood clots.
Okay.
Okay. So now she comes to you, and she says, "My hot flashes are over." You gave her the conjugated estrogen, the Duavi, because of the hot flashes. The hot flashes are gone. She doesn't want to be on estrogen anymore. So she says, "I got dyspareunia. There is a SERM out whose indication is for dyspareunia. Can I switch over to Osphena, the ospemifene?" And so, any thoughts?
Why wouldn't you just stick a vaginal estrogen tablet up her vagina?
Oh, that's crudely put. You know. That's crudely put. She will gently insert a applicator with soothing cream
No,
into the
it's not
vagina.
that messy stuff. It's the little pill.
Okay, you can use the pill too. But then you're inserting a hard pill. But
Oh, wow.
it's 5 years from now. Again, the osperophene doesn't bother me because again, it's a serum. It has in animal studies. They haven't again done the 7 years of human studies. In animal studies, it does decrease breast cancer risk. Her main problem then, since her hot flashes are gone, she's not osteopenic. You know, assuming the bone mineral density, you know, has an osteoporotic. She's not osteoporotic. So I worry more about her breast cancer risk than her osteoporosis.
What about thrombotic events? How about
Yeah, and this says it carries the same risk. That's why I put at the end no blood clot risk. So this will be an evolving story with all the serums and the new serums that are coming out. But the main point is if you have a patient, I have a patient now that's on raloxifene, Avista, and then and the serums are different. That's why they're called selective estrogen receptor modulators. As you all know, the estrogen molecule is a long molecule, or not the estrogen receptors is a long molecule, and on there's a bone part, there's a brain part, there's a heart part, there's a brain part for hot flashes, and so you can get, it's selective because the raloxifene is really good for bone, really good at preventing brain, a hot flash, really good for preventing bone and breast, but it's horrible for brain, so they increase in tamoxifen, increase in hot flashes. So it's a bad hot flash drug. In the middle there is vaginal health, and it's not such a great drug for vaginal health. So they all do different things. So for her, or for a patient that comes and says, now I want a drug that's indicated for dyspareunia, but they're already on raloxifene, I don't keep them on both. There's still enough overlap that I'll pick one or the other. And you take the highest risk, you take the biggest problem. So for her, with her breast cancer family history, which is really pretty bad, and I would have screened her for BRCA, I would lean more toward continuing on a serum, but just pick one of them. And based on her symptoms, I would probably switch over, but I wouldn't put them on both. So, all right, we'll do one more quick case. So this is a slightly older woman, again, still young and in relative terms. Again, small, short, but overweight. 15 years postmenopausal now. She's still smokes. Takes nightly scotch. She actually did take scotch. This is a real case. But I added, she's watching the British Open, which is in the morning, so it's, she drinks more than that if she's drinking scotch, because they're going right now.
Especially last week because the wind interrupted it. So.
Yeah, they're in the 10th hole and the weather's great. They're all going to shooting great scores. She's on hydrochlorothiazide, multivitamin. She's class 2. She's a type 2 diabetic. She has osteoporosis, and she was started on bisphosphonate. Okay, she didn't like, within 2 months, she didn't like the oral bisphosphonate. She's had a DVT, she's had breast cancer, she stopped her tamoxifen 6 years ago. She doesn't move very much, and what are you going to replace the oral bisphosphonate with?
She didn't like the oral bisphosphonate, so she didn't like to take it. She got heartburn, she got GERD, she got bone pain.
With scotch. It gave her a
Well, hey, do I have an IV answer for that?
Yeah, not going to happen. She's not going to stop her scotch.
Well, no, she doesn't.
She's not stopping her smoking. She's not stopping her eating.
Zoledronic acid. She won't have to stop her scotch, and she.
It's for her. It was a choice between zoledronic acid, denosumab.
Or denosumab.
Denosumab.
Or Forteo.
Or Forteo. So, but these are typical. These are not typical. These are real patients. So let's see. We're past our break. Our time.
Well, but you ran over. We ran over saying hi, hey, hello. So
okay, it's okay. Any questions or any?
And we're not going to have a break. We're going to have Dr. Phillips, right?
Yes, sir. Yeah. Welcome back.
Ooh. we are theoretically putting them at risk for osteoporosis. But, you know, they're young, okay? They're not going to fracture, and you don't care don't get a DEXA. You don't care what the Z-score is really, because they bounce when they fall. So there's not a good correlation with bone mineral density and fracture. What you have to make sure is they don't smoke a lot, they don't drink a lot, they take in some calcium, and their vitamin D is okay. They're probably going to be okay. Because what percentage of people? It's about 50% of people are protected with ordinary dose, 86% with 0.625 of Premarin,
right,
and about 50 plus percent with the new oral contraceptive bone protection.
Right. Well, yeah, but that's the one difference. The case before, she was young, so I mean, she's in her 20s and her 30s, and especially when you're in teenagers in your 20s, your low dose estrogens are not high enough for you're accumulating your bone density during those years. When you're 45 to 50, and that low dose birth control pill is enough estrogen to maintain or prevent this. You're really preventing. It's an anti-absorptive. You're preventing the loss of bone. You're not losing bone when you're in 20s and 30s. So putting them on early isn't hurting them.
Unless they have low calcium.
Unless you have low calcium, and you got
the other risk factor.
Right, but there's a different time. They're growing bone, so that's not going to bother. But when they're it's going to bother them if you're affecting their accumulation of their calcium into their bone. But when they're 45, 50, you're not causing problems with low dose birth control. There was a pill or a patch years and years ago that was even half the dose of the low dose birth control pills, and it was fine at preventing bone loss. What you want to do when you're younger is get bone growth or get better mineralization.
You just have to watch out for risk factors. It's like medroxyprogesterone acetate, which I promised I would mention. But you know, you stop that, they get bone because they're young. But if you keep on forever until they get into their 40s, that's bone. It doesn't come back. So you just don't make bone as well. So you just have to watch those people. Most of them do very well, and 52 to 55% of them are very good. They're fine. It's the people who have other risk factors. Just like when you put people in that middle age group on low dose OCs to tie them into menopause, yeah, you're probably preserving their bone a little bit, but they're still going to lose some as they go into menopause if they have risk factors. So you just have to obliterate the other risk factors, and those people should be okay. I see people all the time that are not okay. I see them fracturing hips in their third decade because they were not okay. You know, they were heavy runners, they smoked, they didn't take any calcium in, and we shouldn't let that happen.
Yeah, we keep forgetting that the equation is really gaining bone and then losing it slowly. And we're looking at these 45, 50, 60-year-olds and looking at the loss of bone and their minus T-scores. It's what's equally important is their gain of bone. That's why you have somebody I've got somebody just came in the other day, 8 years on depot. You know, I'm going to say, they're really, I don't know what we're doing to your bone with 8 years on depot in your 20s and 30s. And we know it goes down. But then what happens is that the studies show you take a teenager, you're on depot for 2 years, her bone mineral density is lower, her Z-score is lower, but you stop her, she gains it right back. But that's because she's 21 and still gaining bone. You do that when you're 45 or 50, you're not going to get your bone, you're not going to gain it back. You're just not going to get it worse. Yes, ma'am. Low dose for birth control? I mean, I consider anything under 130, anything under 30 micrograms low dose. But that's relative. You know, there's the 20s, there's there's some of the drug I talked about is at 10. The estrogen replacements are, around 10. Yes, sir. The people in the UK think that after a drug holiday, you can recalculate the fracs. But you see, what are you doing with a bisphosphonate? You're decreasing the risk of fractures. So you're modifying the classical risk factor effect on fracs. At least we hope. I mean, that's why we're writing all these prescriptions. At least